My GP had said, it's just a small op, only overnight, just, it's nothing. And if I had been anybody else, I would have meekly just gone on down that path.
There's just not an established, guaranteed, evidence-based route in place that there needs to be. I don't know why doctors are struggling to say, oh gosh, okay, a prolapse. Right, how bad is it? What should we do about it? And I don't really know why.
But I think on the other side, women are very poor at talking about anything to do with sexual health in any sphere. My mother never said anything. My aunts couldn't talk about that.
I think there's a growing need from the public for more pelvic floor physiotherapy. There's a lot more discussion going on social media, things like net mums. People can talk anonymously and they're a little bit more open about having problems. There's so much pseudoscience out there. Dr. Google's got a lot to answer for. It's really useful to have something that is hard, fast data that we can use to back up what we're doing.
The NMAHP Research Unit in its early days had quite a wide remit to help people who were interested in a particular research problem or project. So clinicians from across Scotland would come to us if they had a project idea, and through working with the physiotherapists there was a feeling that the treatments for prolapse were under-researched. There was no evidence for physiotherapy and pelvic floor muscle training in this group of patients at all, so we chose to start looking specifically at pelvic floor muscle training in its own right and how that could be used as a treatment for women with prolapse, improve their conditions sufficiently that perhaps they wouldn't need to have surgery in the first place.
Systematic review that Suzanne led showed the deficit and the genuine uncertainties in the evidence around the use of pelvic organ prolapse physiotherapy, and yet at the same time the knowledge that this approach was being used very widely in clinical practice. So POPPY is a very influential trial, and one of the reasons the trial is so influential is it was looking at a longer term effect of pelvic organ physiotherapy. So the amount of follow-up that these women had after the original intervention is one of the particularly influential aspects of the trial, because what it demonstrates is that you can perhaps slow symptom progression for these women with the milder forms of prolapse, and that is hugely important in terms of health economics, but also the woman's quality of life.
10 or more years on from when the review was first done, there's much more evidence, including our own pilot trial and main trial. There have been other studies that have gone on, and actually we've now got over 30 trials in that review. So assimilating that information and presenting it in the Cochrane Review is one powerful way to disseminate that information. There's also the International Consultation on Incontinence, which is a WHO-funded initiative, and we've been involved in writing the chapter that relates to prolapse and conservative management and distributed worldwide, so it's like the Bible of incontinence and prolapse.
In terms of the impact, I've just been at the International Continence Society annual scientific meeting in Florence, and there's considerable talk about implementing this evidence in people's clinical practice setting. But there's also a lot of talk that physiotherapists now have some actual good clinical trials evidence that provides them leverage in terms of saying, no, this is not the service to get rid of, because actually we can demonstrate the worth and the value of what the service provides to women and the long-term potential cost benefit for the service.
Restraints that we have in the health service, they're only going to employ us to do work that is clinically proven, evidence proven. It's also really useful when you're trying to talk to other health professionals, especially doctors, because they like statistics, they like data, and if they know that what you're doing is evidence-based, then it does help to support your work with the doctors.
It's only somebody like me pushing the boundaries. No, I'm not having that. No, I'm not going there. No. And then meeting the right consultant. Boom. Then I got Kate. So I didn't have to have the op, which was the only solution. That was it.
The beauty about the research being done through NMAHP is quite pragmatic, it's quite real. So I was one of the physios that got to be involved in the pilot. It wasn't just a leaflet. We got people coming in for supervised training, and it showed that it worked. So you bring that immediately into clinical practice, because you can then say to women, look, we know that for a percentage of women this works, and that kind of health-based research unit, it has quite a big ripple effect actually.
We're multi-professional, multidisciplinary. We use so many different types of methods and are not afraid to bring them all together. So when you've got large multi-centred studies which are of complex interventions and involve getting on board the patient, the clinician, services across a wide range of areas, that type of unit I think just lends itself so well to delivering that type of research.